All right, well, let's go ahead and get started. As I see, it's 11:30 on the dot, Eastern time. So welcome everyone. My name is Rena Chudgar. My pronouns are she, her, and I'm the Director of Public Health Systems and Services at the Public Health Accreditation Board. And we love to just welcome everyone today to our webinar announcing the launch of our Foundational Public Health Services Capacity and Cost Assessment and accompanying tools to do the assessment. We're really excited to be here today and launch this tool with all of y'all today. A few logistics on the next slide. We are recording this webinar and we'll be making the recording and slides available via our website and sent through follow-up materials after the webinar to those who are here today and those who couldn't join us. You, as a participant, may enable closed captioning on the bottom of your screen. You can click the icon to enable that if you'd like to do so. And throughout the webinar today, we hope that you'll use the chat to engage with each other. Feel free to introduce yourself in the chat now, along with asking questions throughout our time together for our panelists, which we'll get to during the Q&A portion of the webinar today. Our plan for today is really to start with an overview of FPHAB's tools for transformation, our tools and resources that really support transforming public health systems, then turn directly into the assessment and take a deeper dive into creating an understanding of what the assessment is all about, what are the goals, what are the accompanying tools and resources that are available, and then walk through a brief demo of the tool. Again, then we'll have some time for Q&A following that. And we know all of you will be eager to access the tool while we're on the call today. And we'll be sending out the direct link later in the webinar today so that you can access that once we get through some of the foundational information that we'd like for you to have. Before I turn it over to our first speaker, I wanted to really just take a moment to thank all of our collaborators on this tool and launching this tool today. Our collaborators at the University of Minnesota School of Public Health Center for Public Health Systems have been our partners in co-creating this tool. And you'll hear from Jason and Annie today, and also want to thank others on their team, including JP, Rachel, Abby, Sarah, and others. I'd like to thank the Robert Wood Johnson Foundation for their funding and support for supporting creating this tool and around our public health transformation efforts overall, including our project officer, Monique Shaw. And I'd like to thank the FPHAB team, Jess, Janelle, Naomi, Travis, Jessica, Kristen, and Paul, among others, for all the work that's gone in from the FPHAB side into creating this tool. A few other thank yous. Thank you to the 21C learning community for all of your insight and feedback to really ensure that what we're launching today is created from that user-centered design perspective. And I want to acknowledge support from CDC through our Public Health Infrastructure Grant Program moving forward in terms of supporting implementation of the tool and Component A health departments and systems and their work and strategies around using the tool to truly kind of transform public health. Jess will describe a little bit more about the details of that later. FPHAB's mission is to advance and transform public health practice through performance improvement, strong infrastructure, and innovation. And so with that, I'd like to turn to FPHAB's President and CEO, Paul Kienert, to share a little bit more about what we're doing to support our mission through our tools for transformation. Following Paul, Jess Kronstadt, our Vice President for Research and Product Development, will then dive into the goals of the capacity and cost assessment and share a little bit more about that. And then Jason Orr and Annie Seeger. Jason is a researcher with the University of Minnesota Center for Public Health Systems, and Annie is a consultant with UMN Center for Public Health Systems through Seeger Consulting. We'll dive into the demo portion for today. So with those brief introductions, I'd like to turn it over to you, Paul, to jump right into our tools for transformation.
Well, thanks so much, Rena, and adding my appreciations to you and all the hard work you have done in this entire endeavor, along with everyone else that you mentioned. And it's so good to have a chance to share this information with everyone today. If we go to the next slide. So just, I think we're all very aware and of the moment that we're in public health, the tremendous opportunities to transform and modernize our public health systems. And FPHAB is all about building trust in public health by ensuring excellence and bringing innovation to scale. And of course, we're doing that in partnership and in service to all of you from health departments across the country. Next slide. So underneath all of the tools that we'll be talking about, and obviously the capacity and costing tool in particular, is the foundational public health services framework. And just wanting to spend a moment here to make sure and level set on this framework. The FPHS framework is a way of operationalizing the concept of public health infrastructure. So the model outlines the unique responsibilities of governmental public health and defines a minimum set of foundational capabilities and foundational areas or programs that must be available everywhere for public health to work anywhere. And so if you look at the framework, you'll notice that it has two major components. Kind of at the base are the foundational capabilities themselves. So these are cross-cutting skills and capacities that are needed in health departments to support basic public health protection, the programs and activities key to ensuring community health, well-being, and assuring that all community residents have fair and just opportunities to lead their healthiest lives. The 8 capabilities, as noted on the framework here, are assessment and surveillance, community partnership development, equity, organizational competencies, policy development and support, accountability and performance management, emergency preparedness and response, and communications. And if you go to our website, if you haven't delved into the model more deeply, all of these capabilities are defined, and there's some specificity kind of on the website for you to kind of look at and think about how these things are operationalized. The public health programs themselves, or foundational areas, are basic public health topic-specific programs and services that are aimed at improving the health of the community. And these foundational areas, again, reflect the minimum set of services that should be available in all communities. So those are kind of listed across there on top of the foundation of foundational capabilities. Then on top of that, because we understand that that is not the entirety of what public health is or does, are community-specific services. And these are the local protections and services that are unique to your community and are essential to that community's health, and they vary by jurisdiction. So again, the concept here is that you're building on a foundation that then ultimately goes up to the unique services that you have in your community. Next slide. So we do have a whole set of tools kind of in our tool belt at FPHAB that we offer to all of you. They're kind of illustrated here on the slide, but if we go to the next slide, this is a table that's a little bit more, has a little bit more detail. Again, you'll get these slides afterwards so you can look at these. But if you want to click one more time on the slide, this is the new tool that we're launching today. It's a tool specifically to support foundational public health services capacity and costing assessment. So we're going to dive into the details when I turn it over momentarily to Jess Kronstadt. But broadly, this tool complements our other tools for transformation that look at and provide an understanding of the current landscape around foundational capabilities, capacities, and costs. and what full implementation might look like. It complements the other tools that we have kind of itemized in this table. And our hope is that it's one more tool to support a system-wide and health department specific effort around transformation. So with that kind of high level, I'm going to turn this over to Jess Kronstadt to walk you through more details. Jess?
Thank you, Paul, and thank you everyone for joining us. So I want to talk a little bit about this assessment. I'm going to give you the big picture overview, and then our colleagues are actually going to show you a demo so you can get into the nitty-gritty. But for context, this assessment, as Paul mentioned, this process of going through and understanding what health departments are investing currently in those foundational public health services and what they need to invest is an activity that several states in the 21st century learning community have already engaged in using their own state versions of the FPHS model, often really relying heavily on consultants, sometimes using a proprietary process to go through that assessment. And what we've heard from the field and from our 21C states in particular was an interest of what's a national tool. So one that's based not on state specific models, but looks at the national updated FPHS framework. And that the process would be able to collect data in a way that would be uniform across states, but also be really transparent about what that data collection looks like. And so that's why, based on that feedback from the field that this would be useful, and then in consultation with some of those states, we've really developed this tool, which is designed to create an understanding of several things. So the first piece is, what is the current ability to deliver both those foundational capabilities and those foundational areas that Paul highlighted on the graphic? And by ability, we mean both sort of the people power to do it and the expertise. Do you have the right people? Do they have the right time? So really understanding to what extent health departments feel that they're able to deliver each of these capabilities and areas. Another key piece is understanding how much is being spent currently in each of those capabilities and areas. And then I think the fun part, the challenging part, is also, what would it look like if we were able to fully implement this? What types of capacity do we think we would need? And what are those funding implications? If we were to really do this the way we believe we ought to sort of be committed to this principle that these are those capabilities and services that should be available to all communities, what would that full implementation look like? So that we can then determine that gap between where is it we want to go and where are we now, so that that states and state systems can really think through what will it take to get there. If you'll go to the next slide, you'll see that this is really the purpose. The why are we doing this is really to start thinking through, okay, we've looked at our ideal state, that full implementation state. We looked at where we are now. Let's think through, where might there be additional resources to invest? What options are there for shifting resources within the organization or cross-training staff? So if it seems like we're actually, a health department is really being able to meet all or maybe more than is what is necessary in one area, but really struggling in another, how can there be resource shifts or training shifts within that organization? Where might there be opportunities to share resources or services across agencies? So where might there be cases where one agency doesn't have very much capacity, but neighboring agencies do have additional capacity? Are there ways of rethinking how those services are delivered so that the entire population served by both jurisdictions has more access to those needed services? And then importantly, there is the piece of advocating for funding. And I will say, I mentioned before that several of the 21C states have done their own assessments and have actually had some success in being able to advocate for, being able to communicate to their policymakers and to say, this is where we're at now, this is where we need to be, and have actually been successful in getting additional funding concentrated on helping to fill that gap. So those are what we sort of hope that what we've heard from states is why they either have done this kind of capacity assessment or why they're interested in doing that. If you go to the next slide, and we'll get into a little bit more details. Okay, that's what the big picture assessment is. And I think, I'm sure many of you on this call have sort of been familiar with it conceptually, but what is it that we are offering here today? And what we're offering today is a very specific tool to help gather that information that we just discussed. Where are you now? Where do you want to go? And the way it is formatted at the moment, it's an Excel spreadsheet that has multiple tabs, and you'll actually get to see that Excel spreadsheet in a minute. So you'll get into the details of that Excel spreadsheet. One of the cool features, and this just harkens back to the slide that Paul showed earlier to show sort of the continuum of different tools and resources available. We've actually designed this spreadsheet so that it ties really closely into the public health workforce calculator. I don't know if that's a tool that others of you are familiar with, but that's a way of doing a quick calculation for health departments who sort of meet certain parameters to be able to get an understanding of what might be the right number of workers to meet different capabilities and areas. And the way we've designed this tool, the Excel tool, you actually can see here's the information from you fill out part of the Excel tool. It gives you some figures. You can plug those into the calculator, and then here's the output, and how does that inform the rest of the tool? So we've made those two tools to really work very, very closely together. The other big picture piece that I want to talk about is really this emphasis on what this tool is about, and the entire assessment is really focused on those foundational capabilities and foundational areas that Paul outlined. So what we are not interested in are community-specific services, so services that might be necessary in your community but don't fit that national model of what is to be available everywhere. And we also really want to focus on the fact that this is about the foundational capabilities, and those areas are really about those population health services that are being delivered in communities, not individual clinical services, even though we understand that that's something that many health departments engage in. And to help health departments completing this tool kind of wrap their heads around, okay, what counts, what doesn't count, which foundational capability or area do I want to put it in? We've developed a series of operational definitions. So I'm just going to share you, there's a quick little screenshot about what those operational definitions look like. What they do is they take the name of it. So you'll see here the capability that's featured on this page is the one about assessment and surveillance. Underneath that, we have headline responsibilities. So those are like big picture activities, or big picture of what does it mean to do assessment and surveillance. We've broken it down into several different categories. And then underneath that, we get even more granular. Okay, what do those headline responsibilities mean? Here, let's give you examples of specific activities. When you're filling out this tool, for some things, you're only going to be reporting at that highest level, that capability or foundational area level. For some things, you will be reporting at that headline responsibility level. We're not asking you to get to the granularity of the activities, but this resource of being able to see what do we consider in that is really for your reference as you're going through and trying to calculate which items belong within each foundational capability and foundational area. Next slide. The final thing that I want to share before we get into the part that I know we're all excited about to dig into the tool itself is really bringing us back to this overarching picture, remembering why we're doing this. This is about assessing and costing out what the resources are, then potentially pursuing funding to be able to meet those, and also to think through other ways to transform the system. So those are those shifts that we've talked about in terms of shifts within an organization, across organizations, et cetera. And you'll really see there are a whole bunch of different arrows in this diagram to really show that this is not a linear process, that the way we see this tool really helping is that you're going to do some assessment. You may try out some new ways of delivering services. You may get some additional funding, but it really needs to be looped to, okay, now that we have this additional funding or we've tried this new transformation, what can we learn about how well we're able to deliver those foundational capabilities and foundational areas within our jurisdictions. The final thing I want to leave with is this notion of this is an Excel spreadsheet. Any health department could go through, use this Excel spreadsheet, fill it out, which is a collaborative process amongst the members of that health department, which would include both the program staff and finance staff to figure it out. But you could just do it for your own health department and say, what can we learn about this? What we would really encourage you to think about is how could this be done on a state-based approach? So instead of having an individual health department here or there do it, what we've seen to be very effective in some of the 21st century states is that all the local health departments and the tribe, and potentially the tribal health departments and the state health department all fill out a similar assessment and then look across all of those results to figure out, okay, what are those shifts that we need to do to transform as a whole system? And so so we'll talk a little bit at the end about how you might take the results from this Excel spreadsheet and kind of wrap it up into one to be able to see that statewide approach. But as we go through this, I really want to put that idea in your mind that I think the way that this can perhaps best really foster that transformation that we're seeking is really looking across, not on a health department by health department basis, but what are the contributions of all of the health departments within the system. And with that, I'm going to turn it over to Jason and Annie to get into a little bit more details about what this actual Excel tool looks like.
Hi, thank you. So my name is Jason Orr. I'm with the University of Minnesota. I'm going to provide some high-level framing for the tool before we get into demoing the tool. We've put some, I would say, sample data into the tool for demonstration purposes. We're not going to be covering the entire expanse of the tool, all of the different fields, but really just enough to have you understand what the tool is and how it might be used. The Excel-based tool that we'll be presenting today, the focus is to collect high-level data. We're looking at the most recent 3 years. The reason for this is for some of the data that are collected, you might want a basis for comparison. So each fiscal year is fairly different for governmental public health. There's not really a typical year. And in particular, COVID, with both the activities that were delivered and the funds that were received or expended, there are a lot of reasons for why I say looking at fiscal year 2021 out of context, might be inappropriate. So we're looking for some high-level data for the most recent 3 years that can be beneficial for you to understand in context, the FTEs, contracted staff, and how those might differ over time. The tool also collects a little bit more detailed data, and this is really the meat of the assessment, is looking at the most recent fiscal year in identifying effort and expenditures with respect to the foundational public health services. So what resources have gone into foundational public health services, expertise and capacity by foundational public health services. So those are your skills, your staffing, your foundations to deliver these services. We ask about things such as service sharing. So we know that in many areas of the country, it is not just the governmental health department in the county that does everything within their jurisdiction on their own. The state health department might have a role. You might partner with adjacent communities, even other private organizations. And that affects, what resources are needed for you specifically to deliver those foundational public health services. Next slide, please. As a very quick wrap, the tool has some other functions that we built in. We have some ways to do error checking, to assist you in using the public health workforce calculator. This data will provide those foundations, and then to help uniformly collect data, and then give you a way to summarize this information to a final report. Without further ado, I'll jump into the tool and go ahead and share my screen for that. Okay. So I'm just going to cover some of these high-level introductory instructional tabs, and then we'll get into discussing the assessment itself. This first tab right here, the About, gives a little bit of background on this Excel-based tool and some context for why you might use it. We also acknowledge the organizations that have assisted and have led to this tool. So, for example, the Robert Wood Johnson Foundation has provided funding for this. The University of Washington and its public health services and tracking program really had a large hand in the structural framework for this tool. And then with us and the Public Health Accreditation Board and Public Health National Center for Innovations, we're partners in developing this tool that we have today. Many of you have seen similar versions of this tool before, may have used it for staffing up or for other state assessments. What we've tried to do with this Excel-based tool is to really streamline it, simplify it, put in some advanced content controls or error checking to prevent pretty obvious issues or to flag things that might be, a potential outlier or something like that. Just so when you're working through the tool, you don't get to the end of it and something doesn't make sense and you don't know where to go back to. We tried to anticipate where those challenges might pop up. For the demo today, we have the tool zoomed at 110%. I think that should work for most folks. If we ever need to go back to anything, put that in the FAQ and we could go back to any slides that weren't particularly readable. Again, this will be moving at a pretty rapid clip throughout this presentation. So please ask any questions if we gloss over anything. From the second tab here we have is gives high-level instructions and overviews of the different tabs that are in use. So throughout the presentation today, we're going to briefly discuss each of these different tabs and the purpose and function for each. We also on this tab give a little bit of color coding for some of the cells that you'll see. The tool as you receive it will be, each of the worksheets will be protected. So things that are not data entry cells, things that are, say, the calculated cells are things that you won't be able to, directly, modify. And that helps focus for you on the user input cells that you might have. We also identify what different colors or types of flags are in this tool. So for example, we felt it would be beneficial to give you a data flag that was a different color if we think that, say, the salary data that you put in was too low for a position versus if that salary data was too high. So we tried to have different flags to indicate the different types of issues that might occur. Next, we have definitions tab. So in the materials and links, there is a separate document that had a PDF that has the list of these operational definitions. We also include them here for reference. And then this framework right here is used for reference in different tabs and places in the workbook. Again, the operational definitions are, we have this national foundational public health services model, but drilling down to a little bit finer detail on, what specific activities are, how to consider, what services you're providing and how to fit it into the model. We encourage you to, even though a lot of the assessment is either at the capability and area or headline responsibility level, to be familiar with the activity level definitions and things so you have a better understanding of what should fit within that. Last but not least, we provide a glossary for some specific terms and concepts. So for the occupations, we have a brief description for each occupation, descriptions for what we mean by the revenue sources that are listed in the background tab, and then descriptions for the different expenditure categories that you'll be entering data into for current spending and full implementation. With that, I'm going to pass over to Annie Seeger, who will help us go through the data.
Great, thanks so much, Jason. And one thing we want to note is it is pretty important to complete these data entry tabs in or worksheets in order. So we are going to review them in order, and you'll see how they connect from worksheet to worksheet. We're starting with the background worksheet. This is a worksheet that collects data that provides context for the overall assessment. Some of the data that you'll input here also follows through into future worksheets, which will try to show those connections. It's also really important to supporting comparisons among respondents. So if you were to work with a partner, or if you wanted to compare your results to another, these questions are very important to making sure that we're doing an apples to apples comparison. I think we've all heard the adage that when you know one health department, you know one health department. Some of these questions help us to create that baseline comparison. So for example, we can make sure that FTEs are equivalent if you use different FTE definitions. There are 8 questions on this page, as well as these input fields up in rows 3 through 7. We're not going to cover every single question, but we'll just briefly discuss them, and we'll get into the questions that are more or less self-explanatory. Of course, you will enter your agency name and the fiscal year. When we're talking about the fiscal year, this is the year that you're going to be doing the assessment based on. And so it's kind of the reporting period. We want you to use your most recently completed or audited fiscal year. So, many of you may have audited data for 2022 right now. That would be appropriate. Some of you may not, and it may make sense to use 2021 data. You can also use a less recent period if there's a reason for it. I think knowing COVID-19 has been out there in the field, most people probably are not going to be using 2020 for that. Like I said, there's 8 questions here. I'm not going to go into each of them in detail. The first is just your fiscal year period. Are you on a calendar year? Are you on a state fiscal year? I think most local health departments are on that calendar year of January to December, but others may be on other years. The FTE definition is how many hours are in your FTE equivalency. Most commonly, folks are on 2,080 hours, but there's lots of other examples. I know that there's health departments that have a 37.5-hour work week, and so they might have 1,960 hours as their fiscal year. The third question is to understand your staffing. We ask for some background data on previous fiscal years, as well as the reporting period, which is fiscal year 21 in this case. You'll just put in the number of FTE, and then for the reporting period, you'd also provide the number of staff. Those are 2 different things. So the number of staff is how many people play any role in your organization. And then the number of FTE, or the actual FTE that they worked for that fiscal year. So you'll see that there are often, you'll have a full-time person who worked the full year. That would be 1 FTE. You might also have someone who worked, less than the full year. Maybe they started 2 months into the fiscal year. And so that is our example with the animal control worker, is we have 0.83. They worked 10 out of 12 months of the year. And so they were 0.83 FTE. There may also be staff, and our example here is the epidemiologist or statistician. There might be staff that are not full-time. You hire them for a percentage of their time, or they're, part-time. And so our example here is a 10-hour a week epidemiologist or statistician. That's 0.25 FTE. And then there might be lots of occupations where you have multiple staff. And so our example here is the registered nurse. In our example agency, we had 7 registered nurses, but they're a combined 5.5 FTE. We would always expect that the number of staff is a little bit higher than the number of FTE. The one sort of counter example is if you have someone who's receiving some compensated overtime, you might have 1 staff member and then a little bit more than 1 FTE for that position. So our next question, scrolling down, is to just ask about any non-employee labor effort. So what we know is that there's lots of health departments that have other work being done through non-professional staff. And so this might be, you have a labor replacement contract where you are hiring out staff, temp employees, union employees, whatever other relationship. You might have personal and professional service contracts. So maybe you contract with someone to do your community health improvement program or something like that. And then you might also have temp employment contracts. So we want you to go ahead and just estimate the number of FTE that those contracts replace. And this is going to be really difficult for some. You probably have some contracts that don't have a one-to-one relationship with an actual professional staff. And so you are going to have to make an estimate there, but that is appropriate for our planning level work. Question 5 is really to get a sense of your total expenditures. And this is something else that will follow through in the assessment, but we are categorizing expenditures into 5 categories for the purposes of this assessment. The first is kind of personnel costs. So those are salaries, wages, fringe benefits, anything that is related to funding individual employees' work. The second are direct contracts. So again, this is where those labor replacement contracts, personal and professional service contracts, and temp employment contracts will go in. So anything that's really replacing labor contractually would be in there. Other operating expenditures, this is where things like materials, supply, postage, travel, those sorts of expenditures would go into other operating expenditures. Anything else other than personnel or direct contracts that you need to do your day-to-day public health business. The fourth are pass-throughs and transfers. So one thing we know is that in the governmental public health system, there are a lot of relationships among governmental public health providers. If a state system were to do this assessment, what we don't want to do is double count dollars that are flowing through multiple agencies. So for example, you might receive dollars from your state agency. They're passing those through to your local agency and you're spending them on the ground. So this is where you report anything that you're not spending on the ground for governmental public health. And then lastly, capital expenditures. So there may be activities that you're doing that are capital intensive, where you have fleet, you have public health laboratory equipment, or any other sort of depreciated large cost. Those expenditures go into capital expenditures. The last couple questions here are revenues. So we do ask you to report your revenues in question 6. And then scrolling down, there's our last 2 questions, which is just your population. So you're in your jurisdiction, what is the population you serve? And then lastly, there's some room for feedback in question 8. So that's our background tab. We're going to scroll next to our current spending worksheet. The current spending worksheet is where you are going to retrospectively allocate your actual spending for the fiscal year of the assessment. So our reporting period, again, in our example, is fiscal year 21. What we want to do is understand what you spent in fiscal year 21 against the Foundational Public Health Services framework. For the purposes of this assessment tool, we're asking you just to allocate your staff and costs against the foundational capability and area level. So what you'll see is in column 9, or in row 9, excuse me, you can see the foundational capabilities and areas. And we're asking you to retrospectively allocate time for all 5 of those expenditure categories across those foundational capabilities and areas. We're going to look at a couple examples here. What you'll see is that the FTE that we identified in question 3 previously, has flowed through here. We have, our 1 agency leadership position. We have our 0.83 animal control worker. We have populated their salary and benefits. This is exactly what you would do if you were completing the assessment. This is about your actual spending and your actual FTE. So when you put in salary and benefits, I know our numbers look kind of round, but what you would actually do is access your payroll system and pull down the actual salary and benefits for that staff member and include them. We put them separately, salary and benefits, but you actually could provide them in a combined format. So you could put salary and benefits together. The reason we put them separately in the tool is that we find that if we just list it in one column, it's really easy for people to forget to include benefits. And we want to make sure that we're very explicit about the fact that this is all personnel costs for those staff members. One thing that you'll see here is we have some flags in. So in row 10, agency leadership, you can see that the total labor cost is flagged. It's because it's higher than what we would expect. We put a flag in here for about $145,000 per year. Those flags do not mean that there is a problem. It's just identifying an outlier, and we want to make sure that the numbers make sense. In this case, I would say that is a reasonable salary and benefits for agency leadership for a full fiscal year. So I'm not going to worry about that flag. Similarly, in row 16, our epidemiologist or statistician, you can see that there's a total salary and benefits of $3,500 a year. That is flagged in blue in column K because it's lower than we would expect. And we think that it's probably not enough salary and benefits for them to even be making minimum wage. And so we would want to check and make sure, is that the appropriate? And my guess is in this case, we missed a zero. And so this should actually be $30,000 and $5,000. So we'll just go ahead and put that in. You can see how that flag goes away. To allocate staff time, you allocate based on the total FTE. So if our agency leader here is 1 FTE, I might say that he or she is doing 0.1 of his time in assessment and surveillance. Maybe I think they're putting 0.25 of their time in policy development and support, and then the remaining time in organizational competencies, which is where like finance and leadership belong. It's really important to review those definitions to really understand where your staff are doing their work and to allocate their work based on what they actually did in fiscal year 21. So that's the personnel allocation. We also do allocation for the other 4 expenditure categories. You can see here, we're looking at direct contracts. Here's an example. We have a shared service agreement for $50,000. In the case of the other 4 expenditure categories, we're allocating on the basis of the actual dollar amount of the contract. So let's say the shared service agreement is that I have a partner who is doing all of my emergency preparedness and response work. I would allocate that $50,000 to emergency preparedness and response. We'll go ahead and show you what that looks like. And you can see when I allocate the full dollar amount, it clears, that percentage allocated becomes 100% and we're good to go. So we're not going to go through further examples. It is similar for the other 3 expenditure categories, but the important thing here is that we want our total expenditures to match what we reported in the background tab. So that we're reporting 100% of our expenditures for fiscal year 21. One other note is that you may have activities and expenditures that were spent on non-foundational things. There is space here to report that so that things do total 100%, even though we would expect only a share of your total expenditures for the reporting period to be foundational and a share to be non-foundational because they're, individual interventions or things outside of the purview of public health. So lastly, we're going to go to the self-assessment tab. The self-assessment tab is where we're going to, get an understanding of what your agency was able to implement with the resources available in the reporting period. Something I want to say here is that, we know that local health departments largely do not have the resources they need to fully implement foundational public health services. This is not intended as a performance evaluation. Again, it's just telling us what can we do with the share of resources that we had compared to what we totally need to fully implement these activities. And this is again for fiscal year 21. The first 2 questions are our self-assessment. We're asking based on 2 criteria, expertise and capacity. And you can see there's a rubric here above that we're highlighting. Expertise is like the skills, knowledge, experience, training to do the work correctly. Capacity is like, do you have enough people and enough time in the day to get the work done? It is possible to have all combinations of scores, and you can see that we've populated these so you can see a range of scores. I'm going to highlight the 2 that I think give people the most pause. So one is having high expertise and low capacity. It is very common in health departments that you might have great expertise to do something, but you just have one person or not enough of their time to really fully implement it. And so that might be an example where, yes, we have the expertise, but we just don't have the capacity to use them in that area. And so we have, a high expertise score and a low capacity score. The counterexample, which is sometimes not intuitive for folks, is that you might have low expertise and high capacity. And what this means is that you might have something that you are required by grants or contracts to do, and you must do it. A great example is like your finance work, your medical billing, anything you're legally obligated to do, and you might be doing it. You might even be doing it really well, but you might not have the right expertise. I cannot tell you how many local health departments I've talked to where we have, our very limited public health nursing staff doing finance work. They're doing accounts payable, accounts receivable, medical billing. And it's not to say they're not doing a great job. They probably are. It's just to say, if we had all the resources in the world, we'd hire someone to do our bookkeeping and we'd have our public health nurses doing our public health nursing. So that's an example. Again, it's not a performance evaluation. We actually expect that there will be areas where you're not fully implemented, and we'd be surprised to see the opposite. The other set of, yeah.
Sorry, quick time check. We just have a little bit over 5 minutes left.
Okay, great. So the last piece here is just the service delivery questions. What you can see here is that we ask a number of questions just to understand for these activities, what are you delivering versus what are partners delivering in your jurisdiction? There's a very simple drop-down menu here. It just has a couple options. So are you sharing this? If you're not, you would say no. If you are, then you would say whether another agency is delivering it and what extent they're delivering it. So you can see here, yes, another agency completely delivers a service in my jurisdiction. The whole purpose of these questions is just for us to understand the percent share of the capability area or headline responsibility that you as an agency are delivering, so that we can put that into the public health workforce calculator on the next tab, which Jason is going to jump into.
Yeah, hi. In the interest of time, I'll just very briefly go over this. So I know there have been previous webinars, and there are guidance for how to use the public health workforce calculator. When we were designing this tool and putting it together, we found that one thing that a lot of health departments struggle with is like, how many people do we actually need? How do we do this full implementation estimate? And the workforce calculator is a really good tool to give you sort of a ballpark or a starting point for that based on the work of previous states. As Annie mentioned, like doing this workbook in order really makes sense, particularly for this workforce calculator, because we take from data that were entered here in the current spending tab for what the total staffing were, making an assumption there, but then the foundational staffing, the percent provided by my LHD was, those percentages in that shared services on that last tab that we were looking at. And these are different elements that are entered into the calculator to arrive at those estimates. The last thing to prep for the calendar would be to indicate what your need for your jurisdiction is relative to your peers. There's a drop down here that gives those different options that are available in the calculator. So following the instructions, entering the data into the calculator, putting this information in, will lead to an output from the calculator where you will find FTE expected. So what the data from the calculator expects you to have in terms of the amount of FTE for your jurisdiction size, for your needs, for full implementation of the foundational public health services. And these data right here as an output can be sort of guidelines for you when putting together your full implementation estimates. We take these numbers here, this FTE expected, and we pre-fill it into the full implementation workbook right here. So when you put in your staff that you think that you'll need, and then you allocate that effort, very similar to how you did previously for the current spending workbook, you can see, if you're hitting the target that you think you might need to reach with respect to what the calculator has estimated your need to be. The calculator is not perfect. It's not going to know your jurisdiction's unique needs. There might be a variety of reasons for why you need much more or much less staff. But generally speaking, this is a good starting point if you really don't have a good, strong understanding of what effort is needed. We do put some ways to check to provide you some context with the data that you're entered. So this row right here can more or less tell you like where you are with respect to this estimate from the calculator. So, 0.61 FTE was allocated, 0.61 FTE was expected. So, there's really not a difference here that is needed. Whereas, if you allocated 0.71 FTE here, but you needed 0.75, then it tells you that there's a little bit less. The last thing I'll show is we did put into the calculator certain minimum values that you might need to hit, even if you're not using the calculator, what minimum values for these foundational public health services you might need. So we did place a flag if, for example, like this value is less than that minimum value. So for emergency preparedness and response, it would need to be a little bit more. But otherwise, filling out this full implementation worksheet is the exact same as filling out the current spending worksheet. You are just trying to look forward to the future. If you had the resources, if you had the approval and authority from your boards of health to hire, and if all barriers were removed, this is who you think you need. This is what spending you think you need to fully implement those foundational public health services. Lastly, the last thing we'll show, so you entered in all of this data, it's all in different tabs, but we put together a summary tab to bring together the most important elements with respect to foundational public health services. So you might have entered, say, in current spending to make your numbers balance, like individual or clinical services. Like if you have a WIC staff person who's at 1 FTE, half of their time was spent doing, individual work with WIC clients. The other half was, say, doing like a community-wide nutrition campaign. To make the numbers simpler in your head, we allowed you to enter in that individual or clinical time here, but this is excluded from that summary. But the summary shows what you entered in for self-assessment, for service delivery. It rolls together all of your labor expenses, contracts, other things based on the data that you entered. Same thing for full implementation at each foundational capability. It rolls together what those FTE costs, total expenditures, to give you a high level understanding of what you have. And then at the very bottom, you can see totals for total staff you need for full implementation, total labor costs, things like that. Lastly, we won't go too much into detail on this, but we did put a couple of columns together where we provide some high level totals and flags for differences and things like that. So you can see, like, for context, these are the total FTE that you said that your agency had for these years. This is the total FTE that you said that you had available in, say, fiscal year 2021 for that. And this was the total amount of FTE that was allocated for foundational public health services, leading to 100%. We'll have some additional materials and resources through FPHAB and FNC to come out later to provide a little bit more context and support for this. But we really hope that you'll go ahead and use this tool. And with that, if we could send the screen sharing back to you all, we can do the question and answer.
Great. And just a few things before we get to the question and answer. Really, the question is the now what. So if you were a single agency, we're going to tell you in a minute how you download the spreadsheet and the tools, but you could fill this out and begin to think through using this information, how to increase or shift capacity within your health department, how you might want to advocate for additional resources, et cetera. If you want to do this as a state-based approach, which is what we really encourage folks to think about using it in that broader perspective, there is a missing step. So at the moment, this is an Excel spreadsheet. So if you were to do it on a statewide level, you would have all the health departments in your state fill out their own spreadsheets. And then there's that missing step of how do you compile those data. FPHAB, and we're working with University of Minnesota. We are developing resources that can kind of help guide you. How would you do that process of compiling that information? We would really encourage you to reach out to PHNCI first before you start that statewide approach, and just talk to us to say, let's figure out what do we need, what kind of guidance is going to be available directly through FPHAB and PHNCI through everyone. Is there additional consultation that we need if we really want to implement this to make sure that we're getting the data in a standardized way, that we're compiling those data, that we know what to do with those data. FPHAB and PHNCI will provide the support we can, some general guidance. We cannot provide that very, very detailed full implementation. things ourselves necessarily, but we will talk with you to be able to put you in touch with those consultants, like perhaps the folks that you're meeting on this field who have that, and we can talk about sort of what it would take to get that sort of full implementation support. So please do reach out to us first to kind of understand what your plan is, see what we can do to support you, and see where you might need to look for additional support or resources that can do that. I will just say that we know that this is an integral part of the public health infrastructure grant program, this ability to be able to do an assessment on foundational capabilities. So if you are considering doing this as part of that statewide approach, we would consider, we would ask, we'd be happy to work with you to figure out what additional resources you might want to use from that component A2 funding to be able to make sure that that you're able to collect all of these data in a standardized way and use it to support transformation. The other thing, and there have been a couple of questions about this is an Excel spreadsheet at the moment. We do have plans to build it into a larger data system that we're building, which is called the Public Health Infrastructure Data System. So the plan is that there will be a way to be able to both input the information through an electronic system and have some of that compilation happen through that electronic system. Until then, the reason we're launching this Excel tool now is that we know that there's a lot of demand in the field. So we didn't want to wait until we could build out this larger platform. We wanted to be able to put this in folks' hands now if they're interested. That also, the other advantage is it gives us a chance to see how it works. So maybe we'll realize there's something in here that we need to adapt. And so it's easier for us to learn that and kind of pilot with folks who want to use the Excel one. And we'll really look for that feedback and incorporate it when we build it into the system. The other piece, and I think there were a couple of questions that came in about this, because it's an Excel spreadsheet now, we are not collecting those data back. We are not aggregating them. Once we move it into an online system, then we do have that potential to collect that data, aggregate it, use it for analysis. And we are happy to talk to states. So if you are a state and you're like, we want to get started right now, so we're going to use the Excel tool now, and you want to talk to us about what it would mean to ultimately, if you wanted your data to be part of this larger system to allow for that aggregation, we're also happy to have that conversation. So that's just another reason why we really encourage you to have a conversation with us if you're thinking through how might I deploy this across the state. So finally, I want to get to the next question, the next slide, which I think is what we're all waiting for, is how do you access this? So there is a link on this slide, and we'll put it in the chat too, about how do you access this resource. You'll notice when you go to this slide, the first thing it does is it asks you to fill out a very brief survey. That's really just so that we have your contact information so that we can follow up with you and get feedback from you all and see how it's working, because again, we really want to be able to continue to improve the tool. So we want to know who you are, who've expressed an interest in this tool so that we can reach out to you and get that feedback. Once you fill out that survey, you'll gain access to the Excel spreadsheet that you just saw. And just in case you didn't catch every single word that Annie and Jason said, or you have some very specific questions, there's a user guide that goes through and talks about every single field on every tab to explain what information we're looking for then. So we are going to make this recording available. You're welcome to watch it again, but you also will have it in writing, tab by tab, field by field, what they are, what those data error codes that Jason mentioned, those flags are, all of that information is in the user guide. And then, as we mentioned, there are operational definitions, which we showed you to help really interpret what counts under which foundational capability or foundational area. We are developing additional resources. The user guide, for example, is a very technical user guide. We're going to develop other resources about how do you use this information, how do you gather that information. So we encourage you to stay in touch with us. And since we will have your contact information, we will let you know as additional resources become available. So with that overview, I'm going to turn it over to Rena, who's going to facilitate the question and answer.
Great. Thanks so much, everyone. Jess, Annie, Jason, Paul. That was a great kind of overview around the tool, FPHAB's tools for transformation, and the demo. We've gotten a lot of energy around questions, so I'm just going to remind folks, keep the questions coming. We'll get to what we can in our remaining time together. And we're going to focus on those that are related to kind of the tool utility or specific questions about the tool overall. Any questions you have specific to your use case, your health department, your specific circumstances, we're happy to talk through with you. Feel free to email us, but we probably won't get to those today. in terms of specific use case questions. So my first question, and Jess, I'm going to toss this to you first and then see what others have to add here, is around just generally speaking, how does this tool accommodate for different health department structures? So we have animal control, we don't. We have a variety of different job titles, others don't. So if you could just talk a little bit about the basis of the tool around the foundational public health services and what that means for the use of the tool.
Great, thanks, Rena. I think that's a really key point and why we started with and showed you those operational definitions, because part of the question in terms of which functions are provided or not. So part of that we'll get into, are they part of that foundational public health services framework? So if it's something that's specific to your jurisdiction, you know, like animal services that hasn't been considered in the model as something foundational to be available by all health, you know, for all folks served by all health departments, then that wouldn't be included in those numbers here. I think Jason pointed out, we have a place where you can kind of capture that off to the side, but that's the whole purpose of using this national model, is to try to say, here are the services that we've agreed on through a national consent, you know, process where we got feedback from the field to really understand what counts as foundational. And that's how those will, you know, so those services that are sort of unique to your health department will not be captured within that foundational data. The tool is meant to be flexible to accommodate those differences in terms of job titles and information like that. So you can, you know, call it what makes sense for you. We do have some sort of guiding things to help you kind of relate to how would you, you know, what would the term be? So we actually have in the glossary, these are what these job categories mean. So you can kind of match up, okay, this is what we call it, but here's how it's described, sort of, again, to get sort of that uniform data. Here's sort of the uniform definition of it. But for that flexibility piece, we also added a few rows at the bottom. So if there's something that doesn't seem to categorize well with the information we provided, there's a way to add that in.
Thanks, Jess. Jason, Annie, anything you would add on to that?
I think very briefly that the one thing that I would say is, so for jurisdictions where, you know, maybe your health department does not do, say, environmental health, and like planning and development in your government does environmental health. This tool and many other tools previously and assessments previously were focused on the health department and the health department's revenues, expenditures, staffing, and things like that. And that's how that system was defined. And that is the limitation. So like if this were being done, you know, say for the government as a whole, it might capture some of those others right there. There are different ways that you can include some of that information. Like if your health department provides funding for those services, but you don't deliver that, there is a pass-throughs and transfers category where more or less you say, this is what we are paying out for these environmental health services to be delivered, for example. But again, you know, this is a very health department centric assessment. And one of the limitations are, you know, public health services delivered outside of governmental public health. But there are comment fields for you to note things such as that.
Thank you both. All right, bear with me here. I have a multi-part question because I think several of the questions that have come in are all interrelated. So these bunch of questions are all related to health department size, systems approaches, health department approaches, and use of the tool. So the first part of this question, and I don't want to spend too much time here because as Jason shared earlier, we do have a variety of resources available related to the public health workforce calculator specifically. But I'd love for y'all to share first, one, just briefly, if you could touch on the current use case for the public health workforce calculator, and then specifically for those who don't fall into that use case, can they still use the FPHS capacity and cost assessment and the workforce calculator tab? And just talk a little bit more about what they would do in that circumstance. So Annie or Jason, I'll start with y'all for this one.
I think Annie, if you want to start.
Sure. So as most of you know, the public health workforce calculator is designed for agencies serving fewer than 500,000 population. I actually think there's a strong desire to make it serve larger agencies. It's just that right now we do not have the data that is needed to do that. And so we do not recommend using that workforce calculator independently for agencies serving greater than 500,000. Actually was following the chat a little bit. And I know that someone, said, well, my population's 515,000. I think you could use a calculator pretty safely at 515,000. But for those of you that are state agencies or that serve greater than 1 million, I mean, it really is not the best tool for that. You can still fill in that tool. It will still generate estimates. What we know is that when we look at per capita costs for like our cost curve for delivering these services, once we get greater than 500,000, the per capita cost starts going up again. So we have sort of this like sigmoid curve. And so what we expect is that if you were to use a public health workforce calculator, your estimates might be lower than we think they should be for fully implementing foundational public health services. That being said, the results still have utility. They still give you a sense of where you might need to be. And what we would recommend is just to give them a far less weight when you're generating that full implementation estimate. And if you find that your full implementation estimate is higher than what that calculator recommended, that is probably right on. A comment I would make here is that might be true across agencies. One thing that is fairly common for us is I think there's this perception. If you ask governmental public health what resources they need to fully implement any activity, they're going to give a very high kind of pie in the sky number. That has not been my experience. You all, when you're asked what resources you need, because you're so used to this financially constrained environment, and because I think, you're good government, you come up with estimates that are very conservative. And so this is an opportunity to really think transformatively about what are the resources we need to fully implement these activities in such a way that we can do our work well and we cannot overburden our staff. So, I want you to think about like, what resources do I need so that everybody can work their contracted hours and leave at 5 p.m. and not be doing uncompensated overtime and things like that. And so especially for agencies serving greater than 500,000, I would say just give less weight to those results. And, if you need to provide a full implementation estimate that is substantially higher, that is very likely correct. And I think in the long term, again, there's desire to make that calculator work for all.
Thanks, Annie. Jess, anything you would add from this perspective? All right, I'm going to keep us moving here because we've got about 5 minutes left, 7 minutes left. The next part of that question is related to different size health departments. So small health departments, very large health departments, freely associated states and territories, centralized, decentralized. Could you speak a little bit to utility of the capacity and cost assessment on a variety of health department sizes and governance structures? As well as, I think, embed in there maybe just a response to a question around what do we do if we are taking a systems approach to different fiscal years and other kind of alignment across health departments. So, I'm just going to toss it to whoever would like to start with that one.
Yeah, I could take this one on. So similar to the response to the last one. So this tool that you use, you're more or less defining the universe, the system that you're working within. So when you say these are the total expenditures of what? Of your local health department, of your multi-county agency, of whichever. Same goes for like the spending and effort that you allocate for FPHS and things like that. Like your output from the tool is, really depends on like what bounds you place on yourselves in terms of what data are included. So even though this seems to be directed as like a single agency tool, you could use it for a multi-county health department or something like that. Now, what you can't do is you can't say, okay, these are these staff, these are these staff, these are this health department's expenses, these are this health department's expenses. It's all put together. But this tool should be agnostic to your governance model, your size, because at the end of the day, like, you still have FTE, you still have expenditures. The biggest challenge that I think that health departments will face, particularly on the size standpoint, is what is considered foundational, like from a staffing standpoint, and what is not. And that's where you see a little bit more intermixing of individual or clinical services with that. And that's what you just need to be mindful of. But generally speaking, it shouldn't matter how you define your system that you're doing this assessment on. And we do in that self-assessment section include areas to where you can discuss how services are shared, either among jurisdictions or between public and private partners. So it should accommodate that information. But again, it's whatever is in the confines of how you define what you're entering.
The only thing that I would add is that states that there have been health departments of various sizes, certainly, who have used this similar tools in the past with success. And B, as Jason said, it's designed to be agnostic, but that's one of the things we'd like to hear your feedback for. If this doesn't make as much sense in your context, we want to learn from that and see, whether there are adaptations or additional guidance. Some of the resources that we're going to provide will, have additional guidance, have some of those frequently asked questions. And so we want to hear from you as you experience it, what questions continue to arise so that we can address those and provide guidance where appropriate.
Thank y'all. So Jason, you started talking a little bit about service sharing. So I'm going to ask us to just describe that a little bit more in terms of what do we do around using the tool, in particular for areas where there are services shared across, boundaries. And I'm actually going to start with Jess on this one, if you want to describe a little bit about the Center for Sharing Public Health Services, and then I'll turn to Annie and Jason to add in.
Yeah, thanks, Rena. So the Center for Sharing Public Health Services has recently been sort of added as part of the FPHAB team. And really that is designed to, we have folks who have that expertise in how do you think through what those relationships can be across a whole spectrum of sharing. So is it a shared service agreement for one very particular service? Is it something where they're, coordinated administrative approaches? Are you actually sharing equally for how to do a project, like doing a joint community health assessment? So we have a variety of tools to help health departments who are considering those shared services opportunities to kind of see where they are on the spectrum, to think through what those preliminary steps are to engage in those relationships. And so that's just an important resource, both. So it could be describing what you're already doing, but as we said, to the point of transformation, we hope that this tool will help you think through, maybe we need to do things differently. And so we'd encourage you to use this tool as sort of an input of like, if we're doing this, multiple health departments in our region are doing it, how can we look across them and see where there might be a strength in one area and a gap in another? Then can we have those conversations and use those resources that we talked about to figure out what do those conversations look like? What are those prerequisites, relationship building pieces we need to have in place so that we can meet the ultimate goal, which is that the communities we serve have access to those services.
Annie, Jason, anything you'd add in a brief moment?
Yeah, Annie.
No, thanks.
Okay.
All right, I'm going to try to squeeze in 2 questions in 1 minute. So let's do it. One, off the top of your head, Jason and Annie, if you could name just one common challenge or pitfall that folks might experience with the tool, what would that be? Just so that can be kind of on the top of folks' minds. So.
Sure. I'd say retrospective allocation is really difficult. You have to think, historically about what you've done. Staff may have changed, so you might be thinking about staff members that are no longer with your organization. And I think especially in that case, there's a tendency to get kind of over precise in trying to allocate. And so the pitfall can really be alleviated by just trying to think a little bit at a planning level, not agonizing. And I recommend a lot of times that folks treat this like test taking. Do the things that you can do easily first, and then come back to the things that you're struggling with at that point, and it should be easier at that point. Jason?
I would just say top 3 pitfalls: using budgeted numbers instead of actual numbers. That can mess you up pretty well. As I mentioned before, conflating individual clinical services with foundational public health services, and sort of drawing that line and understanding where that is. And the third is, I think there's a tendency to underestimate your effort. So being mindful of what do you truly need at a minimum to fully deliver these foundational public health services. And that might need to be a discussion or something to help you figure out what is appropriate there.
Thank you all. So I changed my mind and we're going to wrap up. I know there were a variety of questions we could not get to. We are going to be putting out an FAQ document, so we'll try to address some of these, including questions around what do we do about the impact of current COVID funding and those types of questions in that document. So feel free to reach out to us too if you have specific questions. Jess, I'm going to turn it to you to close this out.
Great. So I just want to thank everyone for participating in today's discussion. And I really want to thank our panelists. We do have a quick poll question. I see some of you have already jumped on that. So we appreciate getting your insights about whether this is a resource you think might be useful. And then we really do encourage you to go to the website that we've shown, access the tool, look through the resources, contact us if you have questions. And we will really be in touch. As we said, to access the tool, we'll get your email address. And so we can follow up as we release things like those frequently asked questions and et cetera. So we really hope that this was just enough of an introduction to kind of whet your appetite. There's only so much we could do in this time. So hopefully we piqued your interest, and then as you have additional questions and want to learn more, we can continue to be engaged. So thank you again so much, everyone. There's also, sorry, I should say there's also a brief survey too. So fill out the poll, and then if you have a chance, take the brief survey as well so we can gather a little bit more feedback. Thank you.